Good morning, everyone. Today, I'll be presenting on the Burkitt lymphoma, a highly aggressive form of non-Hodgkin lymphoma and notably one of the fastest growing human tumors. Understanding this disease offers fascinating insights into the complex interplay of infectious agents, genetics, and cancer development. This disease was first meticulously discovered in 1958 by a British surgeon, Dr. Dennis Parsons Burkitt. While working in Uganda, East Africa, he observed a striking and distinct pattern: rapidly growing jaw tumors, predominantly affecting children in a specific region, notably the West Nile district. His detailed documentation and observation were crucial, leading him to hypothesize that this unique lymphoma might be a link to an infectious agent and appeared to be geographically centered. This discovery was pivotal as it provided early evidence linking a specific cancer to environmental factors and later to a virus, sparking significant research globally. Burkitt lymphoma is not contracted in the traditional sense of an infection. Instead, it develops from profound genetic changes in B lymphocytes, a type of white blood cell often triggered or promoted by certain factors. The most significant infectious agent associated particularly with the endemic form is the Epstein-Barr double-stranded DNA herpes virus. In nearly all endemic tumors, you'll find EBV DNA. In these endemic regions, chronic malaria infection is a crucial cofactor. Malaria constantly stimulates and weakens the immune system, allowing EBV infected B cells to proliferate unchecked. Similarly, in the immunodeficiency related form, a weakened immune system due to the infection of HIV allows abnormal B cells proliferation, often in conjunction with EBV. Regardless of the specific type, the defining characteristic at the molecular level is a chromosomal translocating involving the MYC oncogene, most commonly T814. This places the MYC normally on chromosome 8 next to a highly active immunoglobulin gene enhancers. This relocation leads to the dramatic overexpression of the MYC protein, which drives the rapid and controlled cell growth and division, making it so aggressive. This synergy between the EBV and often malaria HIV and this specific genetic change creates the ideal conditions for this aggressive cancer to develop. Symptoms develop very rapidly due to the cancer's incredibly fast growth. The hallmark is a rapidly growing mass. In the endemic form, this often presents as a quickly enlarging tumor in the jaw or facial bones, interfering with eating and speaking. For the sporadic form, it commonly appears as a large abdominal mass leading to pain, swelling, and digestive issues. Patients often experience systemic B symptoms, unexplained fever, drenching night sweats, and significant unexplained weight loss. Further, spread can lead to swollen lymph nodes, bone marrow involvement causing fatigue, infections, or even central nervous system symptoms like headaches and seizures. Given its rapid progression, diagnosing Burkitt's lymphoma requires immediate attention. The most crucial step is a biopsy of infected tissue. Pathologists examine the cells under a microscope for a characteristic starry sky pattern and perform specialized tests. This includes immunohistochemistry to identify B cell markers and, critically, cytogenetics or FISH testing to confirm the specific MYC translocation. Blood tests and imaging scans like CTs are also vital for staging and assessing spread, and a lumbar puncture may be performed for CNS involvement. Burkitt's lymphoma is considered a medical emergency due to its rapid growth, requiring immediate and intensive treatment. The excellent news is that despite its aggressiveness, it's highly curable, particularly in children. Treatment involves immediate intensive multi-agent chemotherapy regimens, often combined rituximab, a monoclonal antibody which significantly improves outcomes. Due to the rapid tumor lysis, patients also receive intensive supportive care to manage potential complications like tumor lysis syndrome. Epidemiologically, Burkitt lymphoma predominantly affects children and young adults. The endemic form is most common in children 4 to 7 years in equatorial Africa, correlating with areas of hyperendemic malaria. Males are more commonly affected across all subtypes. The prognosis has significantly improved. For children, cure rates often exceed 80 to 90% with prompt and appropriate treatment, and full recovery is a common outcome. While challenging, even in adults, cure rates of 60 to 80% are achievable. However, it's crucial to remember that if left untreated, this rapidly progressive cancer is almost uniformly fatal. Future research aims to optimize chemotherapy to reduce toxicity, explore targeted therapies against molecular pathways like MYC, and advance immunotherapy. The long-term development of EBV vaccines also holds significant promise for prevention in endemic areas. I chose this topic because of its aggressive nature, coupled with such surprisingly high cure rates when treated promptly, makes it a fascinating case study in oncology. The distinct geographical distribution and its strong association with infection and immunity also highlight profound public health challenges. And personally, as someone from Kenya, its discovery in nearby Uganda makes the disease particularly intriguing and relevant. Thank you.